afternoon, everyone, and welcome to our webinar, Shining Light on Glaucoma. My name is Michelle Delizalde, and I am the Assistant Director of Patient and Research Programs at Glaucoma Research Foundation. As you've probably heard, January is National Glaucoma Awareness Month, and it is a good time to talk about this sight-stealing disease and to raise awareness about the importance of regular eye examinations to preserve your vision. So talk to your family and friends about glaucoma and do your part to help spread the word. Today, we have a very special guest. It's Dr. Constance Okeke. She's a glaucoma specialist and cataract surgeon at Virginia Eye Consultants, as well as an assistant professor of ophthalmology at Eastern Virginia Medical School. She is also one of Glaucoma Research Foundation's ambassadors. Dr. Okeke completed her ophthalmology residency and glaucoma fellowship at Wilmer Eye Institute. She received her Master's of Science in Clinical Epidemiology at the University of Pennsylvania School of Medicine. Dr. Okeke has an impressive medical career, but she is committed to spreading awareness about glaucoma and has made it a priority to educate glaucoma patients on how to fight against glaucoma blindness. She's already written one book, and she just released her second book, The Glaucoma Guidebook, Expert Advice on Maintaining Healthy Vision. If you want to learn more about her book, please visit the website www.theglaucomaguidebook.com. Please welcome Dr. Constance Okeke.
Hello, I am so excited to be here, and I thank you so much, Michelle, for the opportunity and invitation to talk to this audience about glaucoma. January is one of my favorite months of the year because it's all about increasing awareness about glaucoma. And today we're going to be shining light on glaucoma, and I'm going to be sharing with you some tips to prevent blindness. So what we're going to cover today on the agenda is we're going to talk about awareness. We're going to talk about the importance of screening for glaucoma. We're also going to touch upon treatments for glaucoma, as well as important tips on prevention. And then we'll share some of Glaucoma Research Foundation's information about their hope for a cure. And then we're going to give you some action steps at the end so that you can take information from this lecture and do something that will benefit you afterwards. So awareness. What is glaucoma and what does it look like? And also, who's at risk? Well, glaucoma is an eye condition that affects a certain structure in the eye called the optic nerve. How glaucoma occurs is actually multifactorial, but all the different types of factors that are involved with developing glaucoma cause the same thing, damage to the optic nerve. And when there's enough damage to the optic nerve, it starts to lead to loss of vision. And unfortunately, that loss of vision is permanent because the damage to the optic nerve is also permanent. Right now, we don't have a cure for regenerating nerve tissue, but there's a lot of hope because research is being done in order to work on just that. So when we talk about glaucoma, I mentioned the optic nerve. If you look at the picture where there's a face and there's a cross-sectional view of the optic nerve, in this view, the optic nerve is made up of nerve tissue, and we're born with a certain finite amount of nerve tissue that we should have and allow us to see for a lifetime of good vision. This optic nerve tissue, as we age, will naturally start to degrade. And that's okay because usually it's a slow process. But in patients who have glaucoma, this process is more rapid and the damage happens more quickly. And as I mentioned before, if you lose too much of that nerve tissue, it can start to equal loss of vision. So when I look in someone's eye to look at the optic nerve, typically a healthy optic nerve should look round like a donut. And it should have, as you see here in the picture, a disc rim. And that rim should be thick. And a thick rim means that there's a lot of healthy nerve tissue. Inside the center, there should be an area that is small. And we call that area the cup, kind of like the hole of a donut. In that area, there's not a lot of nerve tissue. As long as that disc rim is nice and thick, that means it's healthy nerve tissue. But what happens in glaucoma as we'll see in this next slide, is that there is a loss or a thinning of that rim. As the disc rim gets thinner from over time, what happens is the center or the cup gets bigger. And we call that process or that happening cupping. So we don't want a lot of cupping, because cupping means that you're losing that precious disc rim, that precious nerve tissue. And as I mentioned before, as you lose that nerve tissue, what happens is that you will also start to lose vision. And glaucoma has been called the sneak thief of sight, because that vision loss is not something that is very obvious. It's actually something that's very subtle. Here in this picture, you see it labeled as a normal visual field. A visual field is a test that we use in order to examine how well a person is seeing in each individual eye. Naturally, a normal visual field, as seen here, should have a blind spot, and the rest of the area should look light gray. That is indicating that there is a healthy amount of normal functional vision. What happens in glaucoma is, as that thinning process of the disc rim happens, there's blind spots that begin to occur. But those blind spots are not in an area that you would pay attention to, which is usually straight ahead. Those blind spots start to happen in areas that we call your periphery or your side vision. And they happen in a way that's still very subtle, not like a sudden blind spot, but just kind of a gradual haze. And since we're not paying attention to that side vision, that gradual haze can actually be very sneaky, and you can be losing vision and not even know it. Now, we can pick these things up on the visual field test, which is why we repeat these tests periodically over the time of someone being treated for glaucoma. And what can happen is, if the glaucoma is not well controlled, is that those blind spots that are coming out on the side, they can work their way towards the center. And at some point, they can get to the center and actually cause central vision loss in addition to that peripheral loss. And that's what we're trying to prevent with our treatments. So we're at a section I forgot to mention that I'd like to try to make this as interactional as possible. So we're going to have occasionally certain chats where I'm going to ask you to take a poll and do a question. And these questions are true or false. So I'd like you to answer true or false. Once glaucoma damages your optic nerve, lost vision cannot be restored. What do you think? True or false? We'll give you a moment to answer the question. I'll repeat it once more. Once glaucoma damages your optic nerve, lost vision cannot be restored. True or false? And as those results are coming in, let's see what we have so far. So everyone's been listening. So yes, it's true that once glaucoma damages your optic nerve, lost vision cannot be restored, which is why it's so important for us to screen for glaucoma. Now, some people ask me, well, what does glaucoma look like? And it's very common for us to see depictions of what glaucoma looks like in images like this. One image will show a normal visual field where there's no vision loss and you see the full picture, and another picture that will show areas of that peripheral vision loss, like I mentioned. But the reality is that this doesn't necessarily depict what everybody sees when they have glaucoma. In fact, I had a patient in my office who had moderate glaucoma and was being actively treated for the condition. And when she looked over at a poster that had an image very similar to this, she looked at the abnormal visual field and said, well, I don't see like that, so I must not have glaucoma. And when I heard that, I realized that it's really important for us to shed light on what glaucoma actually looks like and why we talk about how sneaky it is. So in these next slides, I'd like to give you a sense of what glaucoma looks like. Here we have the first normal visual field or normal field of vision. This is a view of someone who's driving. They're seeing a ball in the middle of the street. They see some children running after that ball. They see some cars on the side of the road. You see the red car at the front and the cars on either side, and also buildings on either side. This is a person who has a normal visual field. And you can see in the bottom left-hand side that normal visual field that I mentioned before that has a natural blind spot. Now, this is a person who has an abnormal visual field. If you look in that bottom left corner of the second picture, you can see that there is an area of darkening, and that's an area of damage from their glaucoma. Now, if this person is looking ahead, driving the car, they can see perfectly down the street. They can see that ball ahead of them. They can see the buildings ahead with cars on either side. But the blur that they can't see, that's really subtle, is those kids that were running after the ball that were in the first picture. And a good portion of the car that was right there in the front, the red car. This is the kind of subtle blur that happens in glaucoma, not something that's so obvious to be able to see. And then in the third picture, this is someone who has advanced glaucoma. You see in that visual field on the bottom left that there's a lot of darkening and graying. Okay, this is areas of loss of vision, and this would be considered advanced glaucoma. But look at the picture. If you're someone who's driving the car, wouldn't you be able to say that you could see really well down the street, all the way down to the cars at the end of the street, and you see that ball? But what are you missing? Look, you're missing that the whole car is gone at the front, the red car. The children are completely gone. Before, in the middle picture, you could see the top of the head of one child, but here you don't see them at all. And then remember that building that was on the left side of the street. You can't see it anymore. It's just kind of a haze. And then also there's a haze of some of the buildings on the left. But you can see and get the idea that this is a subtleness, something that you might actually overlook because you're paying attention to the front. And that's part of the reason why, again, we call glaucoma the sneak thief of sight, because it's making these changes very subtly. And you can have moderate to advanced vision loss and then not even know that you have started to have a problem. So let's get back to the chat and ask a question. True or false? Is glaucoma hereditary? Well, say the question again. True or false? Is glaucoma hereditary? All right, as you're taking that poll, let's see some of the results. So the majority of you, 88%, said that yes, it's true, glaucoma is hereditary. And some of you said it's false. The reality is that it is very hereditary. Actually, a genetic aspect of glaucoma, there's a big, strong component of glaucoma that is a genetic. And so we want to know that glaucoma is a major risk factor, or family history is a major risk factor for the development of glaucoma. So in family members, they have a 4 to 9 times higher chance of developing glaucoma compared to the general population. That means that if someone is a blood relative, they have an increased risk for developing glaucoma. That's why it's important to talk to your family members about it, not because you are concerned about giving them a burden of your diagnosis, but sharing is caring, and you're giving them a gift by allowing them to be aware that they should get screened for glaucoma so they can find out if it's possible that they have it. We know that the earlier that glaucoma is found, the easier it is to treat. So you're doing them a service by that. If you have a collection of family that's coming together, 1 in 8 of relatives, if a person has glaucoma, likely also has it. So it's important for you to know that and take the opportunity to share your diagnosis and encourage your family members to get checked. Some other risk factors that are important for glaucoma, and I'll just take a step back to say glaucoma can happen in anybody, any age, any race, any gender. Glaucoma can affect anybody. However, yes, there are certain risk factors that make you a little bit more likely or to develop the condition. And as I mentioned, family history, also increasing age. As the nerve tissue naturally starts to degrade as we age, there becomes a higher chance that that amount of nerve damage or degradation starts to get past a certain reserve and lead to some type of vision loss. So as you increase in age, your risk factor for developing glaucoma is heightened. Also, certain ethnicities. There are certain types of glaucoma, like open-angle glaucoma that tends to be a bit more aggressive in patients who are of African descent compared to Caucasians. Actually, it can be 6 to 8 times more likely to cause blindness in African Americans compared to Caucasians with open-angle glaucoma. Also, in certain ethnicities of Hispanic descent, there is an exponential increase in the development of glaucoma as they reach the age of 60 and beyond. And then there are certain types of glaucoma. Open angle is one major type, and narrow angle is another major type. Open angle glaucoma is far more common in the United States, but in areas of Asia, narrow angle glaucoma is much more common. So there's also some risk factors related to use of steroids. Now, steroids is something that I always want to remind people about because it's often sometimes discounted. Steroids can increase eye pressure in patients who have glaucoma. And it's not just steroids in the eye, it's steroids that could be injections, like for your arthritis in your knees or your back. It could be in the form of inhalers for someone's asthma, or the form of oral steroids that are taken for other conditions. It's important if you are taking steroids that you get your eye pressures checked periodically to see if you could be what's called a steroid responder. Because if your pressure suddenly goes up and you're not aware that it's gone up, it can be causing damage to your optic nerve. There's also increased risk with trauma in the eye, as well as people who are nearsighted or myopic. They have an increase of risk of developing open-angle glaucoma. And then also, if you've been told in the past that you look suspicious for glaucoma because your nerves show some signs of cupping, like I mentioned earlier, where the disc rim is a bit thinner and the cup in the center is bigger. If you're a glaucoma suspect, you're at risk for the potential of developing glaucoma over time. So you need to be checked regularly to see if there's been any changes. And blood pressure is not a direct correlation with glaucoma, but blood pressure can cause certain problems in the eye that can have an indirect relationship to certain types of glaucoma. And it's known that if you have low blood pressure, that this could cause poor blood flow to your optic nerve, which could be a risk factor for developing glaucoma. So let's get back into the chat. True or false? Getting a comprehensive dilated eye exam is the only way to catch glaucoma early. True or false? One more time, getting a comprehensive dilated eye exam is the only way to catch glaucoma early. True or false? All right, so we should see some of those polls coming in. Okay, so 71% of you said that getting a comprehensive dilated eye exam is the only way to catch glaucoma early. And about 29% of you said that it's false. That answer to the question is true. The only way that you can find out if someone has glaucoma is by looking inside the eye. And this leads us to talking about our next topic, which is the importance of screening. When should you be screened? How often should you be screened? And how is glaucoma diagnosed? So if I look at these eyes and I ask myself, and I ask you, which of these eyes has glaucoma? Even after 20 years of studying and evaluating people for glaucoma, by looking at the eyes, I can't tell, because that previous chat question that we just answered is that the only way we can find out if someone has glaucoma is by looking inside the eye. We have to look at the optic nerve in order to be able to decide, in addition to some other tests that help us to figure things out. So how is glaucoma diagnosed? Well, we check visual acuity, which is something where we have you look at a screen and we assess how well you can see the letters at a certain distance. And this gives us a sense of that central vision. As I mentioned before, typically in glaucoma, the central vision is good until late stages. So this is an important area to screen. The slit lamp exam, we use a tool that's like a microscope that allows us to look at the eye on the outside as well as inside the eye. And we use certain special lenses that allow us to examine the details of the optic nerve and assess whether or not there's damage or not. And if there is damage, assess whether or not it's progressed or not. Tonometry is the way that we measure eye pressure. And eye pressure is very important when it comes to glaucoma because that's the way we treat and manage glaucoma, by assessing eye pressure and manipulating that eye pressure to become lower. So tonometry is the study of being able to evaluate the pressure, and we can do that in different ways. The gold standard is to use applanation tonometry, where you have to numb the eye and use an instrument that's part of the slit lamp in order to check your eye pressure. Then there's gonioscopy, and gonioscopy is a tool that we use in order to be able to look at certain structures of the eye that we call the angle. We use gonioscopy to assess if the angle is open or if it looks narrow, or if there are other areas or characteristics that might be at risk for causing damage in the outflow system. That's where the outflow system is in the angle, where fluid is able to flow through your natural drainage system. So we want this area to be open. Then you have your visual field, as you've been introduced to already, which is a very important test that helps us to stage glaucoma. Is this mild? Is this moderate? Is this severe glaucoma? Where are the glaucoma defects? Are they stable? Are they progressing? This is a very important test that we use in order to determine those things. And then there's also the OCT, and this is a test that scans the optic nerve tissue in very detailed ways to kind of put a number on how healthy the nerve tissue is. And this we can use over time to get detail if there's been any changes in any areas of the optic nerve tissue that allow us to follow a person's glaucoma. There are some other tests that we also use for glaucoma evaluations, but these are the ones that are mainly used for that diagnosis and then following assessment. So in terms of recommendations for eye exams, I often get the question, how often should my eyes be checked, or when should I get screened for glaucoma? Well, the American Academy of Ophthalmology has put out some guidelines and recommendations for people who have glaucoma risk factors, and then people with no glaucoma risk factors. So it's going to be more often and earlier for people who have glaucoma risk factors. Under the age of 40 years, it should be every 1 to 2 years. At 40 to 54 years, every 1 to 3 years, and 55 years or older, every 1 to 2 years. And that's just for screening. If you are evaluated and found to have glaucoma, then the rate of follow-up is going to be much more often, and it depends on your stage of glaucoma. One should expect to be followed every 3 to 6 months if you have early to moderate stable glaucoma. If it's more severe, then you would probably be seen about every 3 to maybe 4 months. And if your glaucoma has been recently evaluated and you're trying to establish if your treatment methods are stable, sometimes you might be seen every few weeks in order to be able to assess if your treatment is stable. And then once it's stable, you move out to months. If you're a glaucoma suspect, then maybe every one year you are evaluated to see if there's been any change. Now, if you are someone who has no glaucoma risk factors, and the American Academy of Ophthalmology guidelines recommend that under age 40, every 5 to 10 years, 40 to 54, every 2 to 4, 55 to 64, every 1 to 3, and 65 years and older, 1 to 2 years. Sometimes people ask me, well, how young can I get someone checked? If someone has a strong family history of glaucoma, meaning that, let's say, a mother got the diagnosis early in her 40s of glaucoma, and she's wondering if her child should be evaluated. If you're concerned about it, I would just go ahead and get the child checked. I see patients even in adolescents that have suspicious optic nerves that I follow. I don't do babies, but congenital glaucoma can occur. So if there is concern, it's better to err on the side of just getting checked and then know how the status of the eye is. Okay, another chat. True or false? Okay, the only clinically proven treatment for glaucoma is to lower eye pressure. One more time, true or false? The only clinically proven treatment for glaucoma is to lower eye pressure. What are your thoughts on that? True or false? Okay, as we should be seeing some of those polls come in. All right, so 86% of you said true. The only proven treatment for glaucoma is to lower eye pressure, and 14% said false. So true, if the answer is that it's true. There are ways that we lower or treat glaucoma, and the treatment that we know works through our clinical experience and research is being able to lower the eye pressure. So let's move into talking about treatment. How is glaucoma treated? What are the options? And what is the first line of treatment? So when we talk about intraocular pressure, understand that it is a separate system from the blood pressure. So there is a closed system within the eye, and we're also not talking about, the tears, ducts, and tears on the outside of the eye. That's a separate system. So when we're talking about glaucoma, we're talking about an internal system within the eye. And within the eye, there is a structure that creates fluid, and it's always turned on. And that structure is called the ciliary body. And it's like a faucet. It's just turned on. And fluid is made in that structure, made in the eye. And there's a certain path of fluid being made and then getting to the front part of the eye and then going through what we call the drainage system. This trabecular meshwork is the medical term, but you can call it the drainage system. Now, the area where the drainage system is, there are structures, a structure called the cornea, which is a clear structure at the front part of the eye. You could touch it with your finger, it's clear. And another structure called the iris, which is what gives you the color of your eye. Where the iris and the cornea come together, they form an angle. And that angle is important because at the apex of the angle is your drainage system. And you want that fluid that's being made in the eye to be able to get out of the drainage system. So when we use our tools to look at this area of the eye, which I mentioned earlier, which is called gonioscopy, we're looking to see if this area of the cornea and the iris, if that angle is open. And if that angle is open and there's still a problem with the development of glaucoma, we call that open angle glaucoma. And if that area, the cornea and the iris, are too close to each other and the area is narrow, the angle is narrow, we call it narrow angle glaucoma or angle closure glaucoma. And what happens in these situations is that there's some type of block of the drainage system, whether internally within the drainage system or on the outside where there's just an obstruction that we can see where the angle's too narrow, but there's some type of problem in the drain. And that causes a backlog. So that fluid keeps getting made, but it can't get out of the drain. And so pressure starts to build inside the eye. And that pressure, as it builds inside the eye, it starts to cause pressure against the back of the eye where the optic nerve is. And the optic nerve is made up of this tissue that's very sensitive to the pressure. And it can start to die off. The fibers can start to slowly die off as a result of this pressure. Now, the higher the pressure is, the faster those nerves tissues can get damaged. And so when I look inside the eye, I can see the optic nerve, like I mentioned before, that should look round like a donut, and I can get a sense of whether or not there's damage to that nerve tissue. So one way I like to explain the concept of types of glaucoma, open angle glaucoma, narrow angle or angle closure glaucoma, is by talking about the sink drain analogy. Now, the picture of A is how it's supposed to work, how the system is supposed to work. You have the faucet that's always turned on, and that's like the ciliary body making that fluid. And then you have your drain that's nice and open and allowing that fluid to be drained out of the eye. And there's a balance of fluid being made and fluid getting out, and that's why there's not a lot of fluid in the sink. But what happens in open angle glaucoma, which is the B, you have the faucet's on, you can't turn it off, and there's some type of clog. And that clog is either at the top of the drain, or it can even be down deeper in the pipes of the drain, but there's some type of clog. And because of that clog, fluid is being made, but it's not getting out in a nice balance. So there starts to be some level of overfill. And in the eye, since it's a closed system, it creates pressure. And like I mentioned, that pressure starts just to cause damage, wear and tear to the optic nerve tissue. Now in C, this is like having angle closure or narrow angle glaucoma, where the faucets are always on and you can see the blockage. You can see the stopper that is blocking the drain, and it's blocking it pretty aggressively. And in these scenarios with narrow angle glaucoma, you can have sudden increases and big increases in eye pressure because that fluid can't get out, and it starts to increase the pressure very quickly. So let's turn into now talking about how glaucoma is treated. And to make it simple, glaucoma is pretty much treated either to try to turn down the faucet of the drain, turn down the faucet, like the ciliary body, turn down the amount of fluid being made, or it's trying to help to open up the drain somehow, okay? And so where there's a clog. And so we can do this with medications that are typically in the form of eye drops, although we do have medications that come in oral forms, and even some of those medications can even be given IV in certain emergency situations. But there's medications. Then there's also the use of light energy treatment. Some people might call this laser, but there's different wavelengths of that light that are used at different structures of the eye. So light energy treatment. And then there's also incisional surgery, where there's some type of incision made in the eye. Now, medications, we have different types of medications. We actually have 6 different classes of medications. And the good news is that these medications can actually work symbiotically, meaning that you can use one medication and add another class of a medication, and they can actually work in an additive effect to help lower the eye pressure. I mentioned before that there's medications. There's a class of medication, the carbonic anhydrase inhibitors, that comes in both an oral form as well as an IV form. Now, the nice thing about our medications is that they're given different colors. So that's why you have different colors on the caps of bottles, which we know that sometimes it's difficult to remember the name of the drop, and it can be very good to communicate what the bottle color is, and that can help us to get a sense of what class of medicine that the patient is on. We now even have technology that has taken some of these medications and been able to put it into a pellet form that can be inserted into the eye with a sustained release of medication over months to even years. Then there is the second type of treatment, light energy treatment. And like I mentioned, there's different types of light energies. There's the laser peripheral iridotomy. You can hear the term LPI, and this is used for narrow angle glaucoma treatment, and its effects help to open up the angle, make it less narrow and more open. Then you have the selective laser trabeculoplasty, or SLT. This is a very commonly used treatment. It's now considered first-line treatment for open angle glaucoma. And what it does is it helps to open up and relax the natural drainage system. So the pores of the drainage system, it helps them open up so fluid can flow through more easily, and more flow means lower eye pressure. So this is a very commonly used treatment for open angle glaucoma. Then you have argon laser trabeculoplasty. This uses a hot energy, where the SLT uses a cold energy. So this is a treatment that also tries to help stimulate opening the natural drainage system. But this is an older type of laser, and it's not something that can be repeated multiple times because it is a hot laser and can cause some scarring if it's repeated. Whereas the SLT laser is a cold energy, so it doesn't cause scarring. And so it can actually be repeated multiple times if it's been effective the first time or the time before. Then you have laser cyclophotocoagulation, and this is technology that uses laser aimed at the ciliary body. And the way that this works is pretty much turning down the faucet, trying to reduce the amount of fluid that's being made by the ciliary body. And there's different forms of this type of laser that can be performed on the surface of the eye or actually inside the eye. Then we have incisional surgeries, where an incision has to be made in the eye in order to gain access to the drainage system. We have our MIGS, is a new term called minimally invasive glaucoma surgery. And this is usually treating mild to moderate glaucoma. In some situations, you can actually use it in severe cases, but typically mild to moderate. And then you have a term that's called LIGS, or less invasive glaucoma surgery. It has a little bit more level of complexity than the MIGS surgery, and it uses conjunctival stents. So a device that helps to bypass the natural drainage system, so creating a new drainage system. And then the trabeculectomy and tube shunt, these are traditional glaucoma surgeries. They've been out the longest, but they do have a higher level of complexity and a slightly increased level of risk. And so these are used in more severe cases of glaucoma. And as I mentioned before with the medications, where the different types of procedures work on different parts of this drainage system, with minimally invasive glaucoma surgery, or MIGS, we're looking at, there's so many of them. To be honest, there's been an explosion over the last decade of minimally invasive glaucoma procedures. There's over nearly 10 different types of minimally invasive glaucoma procedures. And how we try to organize the different types of procedures is by their mechanism of action, how they work. And so you can separate them into 3 categories of using stents, using goniotomy, or canaloplasty. So stents are where you actually have a device. These are small devices, but they are placed in the eye, in the drainage system, to create an opening that's supposed to stay patent over time, kind of like a cardiac stent. So a stent for the drainage system. And you might have heard of terms like iStent or Hydrus. These are stents that can be used to create an opening and try to help unclog the drain by keeping it open. And then you have goniotomy. These are tools that are used in order to actually remove clog material within the drainage system that we can see. So in the trabecular meshwork, we can see some of the clog, and we can use certain goniotomy techniques such as Cahook, dual blade, trabectome, the Drabex Plus. These are different devices that help us to remove some of that clog material. And then you have canaloplasty. This is like using a jelly-like material to try to flush out the drain, to try to flush it out, stretch it out, to make it more open. If there's any scarring, trying to help tease away scarring in the pipes. And so that's another technique with the eye track. And there are some techniques that combine different mechanisms like goniotomy and canaloplasty, like you might have heard terms like the Omni, or the Streamline, or eye track, or the GAT. These are all different types of mixed procedures with different mechanisms of action. So now I want to move into talking about the glaucoma guidebook. As a glaucoma specialist who has seen over the years glaucoma patients who I wish just knew a little bit more information before I saw them and got them at a level of damage where it was more significant and I couldn't go back. This is a compilation of my best pieces of advice for the glaucoma patient, things that I wish every glaucoma patient would be able to know. And also, it's in sections. It's supposed to be kind of a step-by-step pathway to being able to be empowered and encouraged and to be a self-advocate for glaucoma. The first section talks about understanding glaucoma. A lot of the information that we talked about today is within the book. So people have a good foundation of knowledge about the disease and understanding and terminology so that they can be able to communicate well with their doctors. The second part is my 12 best tips of advice, real world advice that I think every glaucoma patient should know. And in a moment, I'm going to talk about 6 of those areas that I mentioned in the book. The third section is for encouragement. I got 5 of my glaucoma patients to talk about their story, their challenges, and also their triumphs in living with glaucoma, so that patients who read the book in that section can feel encouraged and supported that they're not alone, or encouraged to hear some other stories and advice that they might actually want to take for themselves. And then the last section is about resources, practical resources for people to be able to take deeper dives when they're ready, and also practical resources like the section for caregivers to be able to give advice to caregivers for glaucoma patients so they can help the person that they're caring for even better. And so let's talk about some of those tips that are within the book. One is don't ignore the signs. We say that glaucoma is very asymptomatic, especially in its earliest stages, but sometimes there are some signs that people can start to see that they should not ignore. For example, I had a patient who was a avid basketball player and a point guard, and he prided himself on being able to pass the ball and being able to see he was open and pass the ball quickly. As he continued to play, as he got older, he noticed that he wasn't able to do that as well, and he just felt like he wasn't able to see to pass as well as he was. And he called, to said it was aging and kind of stopped playing as much as he did. But the reality was, it was before his diagnosis of glaucoma, and it's likely that his blind spots were causing him to have that difficulty. And instead of, saying, oh, it's just age, he could have got his eyes checked earlier and been able to find that there was glaucoma that was there at an earlier stage, so it could have been treated and prevented better. And some other people might say that things come up on them. All of a sudden, people come out of nowhere, or that they tend to kind of drive up on curves and they don't know why they're kind of leaning towards a certain part of the road. These are signs, and one shouldn't ignore them. Get your eyes screened if you haven't. Then the other piece of advice is to do the cover your eyes so you can see test. Now, this is not specific for glaucoma. This is something that is kind of general for eye conditions, but can't tell you how many times I've had patients who've come into the office for an exam, and until they've been told to cover one eye and then cover the other eye, they just realize that, oh, I didn't realize that eye couldn't see that well because I never covered one eye. The brain wants us to be able to see as well as we can. And so with both eyes open, we see as well as our best seeing eye. And it's not until you actually close one eye, sometimes if you have a problem in one eye, that you notice that there's an imbalance between how the two eyes see. So this is a very simple test that could be done anywhere in order to just do a quick screening. And if there's an abnormality between the two eyes, one should get your eyes checked if you haven't. And then a third piece of advice is to accept the disease. Don't accept defeat. Sometimes people get diagnosed with glaucoma and they just assume that they're going to go blind, and that's not the case. We have really great treatments, and when people are caught early, the likelihood of them going blind is very low. And so we need to encourage patients to know that, yes, okay, you might have to say, okay, I have glaucoma, accept the disease, but you don't have to accept that you're just going to lead to blindness. There's a lot of power in your control by keeping up, by communicating with your doctor, by going to your appointments that allow you to be able to take active control of your disease and try to stay on top of it so you can help and do your part and your best ability to keep seeing. And the 4 is to know what's expected. It's really important for patients to understand that when you have been diagnosed with glaucoma, it's a chronic condition. It doesn't go away. Even if you want to take a holiday, glaucoma is still there. And so you have to know what to expect. And following up is a big part of glaucoma care. If you have an appointment, let's say you're supposed to be seen every 3 to 4 months, and for whatever reason you had to cancel, the doctor had to cancel, don't just kind of say, oh, well, they haven't called me, and so I probably don't need to be seen. They're your eyes, and you need to protect them. And so sometimes, life happens. It's not always a perfect world, but understand that you need to be an advocate for yourself and make sure you make that appointment to get seen so that you can stay on top of your glaucoma and keep things as stable as possible. Knowing what is expected is also knowing that we repeat tests. I mentioned some of the tests that we do, like the visual field test and the OCT. We repeat these tests because they are ways to give subtle information of change, and we want to stay on top of your glaucoma. We don't want you to lose vision. So we do these tests to give us more encouragement and more information to decide if we need to change things or if things are stable. Two things happen with glaucoma when you're diagnosed. Either it's staying stable or it's progressing. And if it progresses, we need to try to do something different to try to slow down that process of progression. The fifth piece of advice is partnering with your doctor. It's really important for you to find a doctor that you trust in order to be able to follow and manage your glaucoma. Because if you don't trust your doctor and they give you information or things to do, and you just say, I might not do it, you have to understand that if you don't follow the treatment regimen that's best for you, it's your eyes and your vision that is at risk. So it's important. If you need to get a second opinion, get a second opinion. If you need to get a third opinion, get a third opinion. It's all about making sure you feel comfortable and being able to move forward with protecting your vision. Also, it's important for you to understand that when you do find a doctor that you trust, it's important to speak up. If there's a problem, any problem, you should let your doctor know. Don't be afraid to talk to your doctor about your problems, because we want to be able to give you the best individualized care. So if you are in meetings and your drops make your eyes red, so every time you're in meetings, you don't use your drop, you need to tell your doctor. There are other classes of medicine that you may be able to take that decrease the redness or if irritation in your eye or whatever the problem is. If it's too costly, there are other classes of medicine, other types of medicine, other modes of even, copay cards or GoodRx, things that could be done to lower the amount of cost so that you can keep on your regimen. Don't stretch the drops. These are things that you need to just talk to your doctor about, and feel free to do that. That's what we want, so that we can make sure that we're doing what we can do to help you to keep seeing. And the sixth point is to make sure you talk to your family. We talked before about how hereditary risks are very important, and the genetic factor with glaucoma is very significant. And so, if you have family members, you need to tell them that if you have the disease, that they need to be checked. And you can do it in a gathering when you have the holidays or when you get together. Just bring them together and say, I want everyone to know that I have glaucoma. And it's not to say that it's to burden you. I'm in good care. I'm being treated, but I just want to let you know because I want to make sure you get screened. Sharing is caring, and I care about all of you. And I want to make sure that if there's any way that any of you could have it, that you catch it early, because I understand that the earlier it's caught, the easier it is to treat. And so this is something that you should share with your family, and also tell them that when they get their eyes examined specifically for glaucoma, let the doctor know that they have a family history. We tend to look a little bit more keenly at the nerve when we hear about family history to make sure we look for any subtle things, and we might do extra tests in order to just make sure that there's no evidence of glaucoma. So that's an important thing to also say. So as a gift to you, because I am so excited about how this book can help to empower patients on their journey of glaucoma and make them even better self-advocates to promote a vision, being able to keep and protect vision. I want to be able to give you a 30% discount on the book. We will give you more information with this HOKE23 code. One is able to use it in order to reduce the cost of the book so that you can make it even easier for you to get your copy. And just to give you a sense of some of the things that other patients are saying about the book, this is one person's who read the book, their comments on it. Upon the initial diagnosis of glaucoma, this book should be simply handed to the patient. Dr. Constance Okeke is absolutely on point with the delivery of thorough, accurate information. The book not only provides an in-depth, clear explanation of each phase of the advancement of this disease, it details the origin and causes. With easy-to-identify photography, graphs, and illustrations, the information given is well-defined and precise. It allows the reader to assess and understand not only the whys of the disease, but the options that are available. Having these important tools will give the patient a foundation of knowledge to begin an informed conversation with their glaucoma specialist. Patricia Caulfield. And with that being said, I'd like to now talk about the mission of the Glaucoma Research Foundation, which is to find a cure and help to reverse vision loss from glaucoma. Their hope for a cure goes into initiatives that they have invested in order to do research to try to help find that cure. So I want to talk a bit about some of their programs. They have Catalyst for a Cure, which was launched in 2002. And over the years, they have had several iterations of initiatives in order to do just that, look for a cure for glaucoma. And the donations that are given to the organization help to fund these initiatives. So the Catalyst for a Cure is a unique model of collaborative research where it brings different scientists together from different backgrounds, different universities all over the country that have complementary skills with a focus on finding a cure for glaucoma. The first initiative was focused on neuroprotection, and it was from 2002 to 2012. And in this initiative, the scientists were able to discover that the first impact of glaucoma is actually in the brain and not in the eye. And they were able to identify a window of opportunity for preventing a vision loss in genetics. The next initiative that was from 2012 to 2015 for the Catalyst for a Cure was focused on biomarkers. And here they were able to identify biomarkers that signaled early changes that led to vision loss. And these findings were able to lead to new clinical trials to help protect vision. In the next Catalyst for a Cure initiative, which is actually still ongoing, this was a focus on vision restoration, and it started in 2019. And here, various experts in different fields in neuroprotection, physiology, cell biology, as well as ophthalmology, were able to develop theories to transplant retinal ganglion cells, and it's retinal ganglion cells that make up the optic nerve tissue. They were able to identify 3 genes that needed to be turned off in order to improve the survival of those retinal ganglion cells. And we're talking about the idea of taking retinal ganglion cells from one place and being able to transplant them to somewhere else. And so we want to be able to find ways to make sure that they can survive. And so they were also able to identify protective genes that needed to be turned on in order to promote the survival of injured retinal ganglion cells and enable these cells to regenerate damaged nerve fibers. So very important findings towards the hope of a cure. Then the next initiative, which is again ongoing, it started last year in 2022, was focused on prevention and a cure of neurodegeneration. And here, these scientists were exploring similarities and differences between glaucoma and other neurodegenerative diseases like Alzheimer's, and doing this to search for potential preventive measures and cures that are cross diseases. Another wonderful usage of the donations for Glaucoma Research Foundation is the use of these grants, monies for the Schaefer Grants for Innovative Research. And in these grants, they are a 1-year grant to different scientists. And over the years, the Glaucoma Research Foundation has funded over 290 of these awards. And what they are is for scientists who have ideas about projects that are very innovative towards helping to find a cure in glaucoma. And there are $50,000 grants that are given as seed money to help to promote and foster their research. So the Glaucoma Research Foundation, part of the reason why I love this organization and I'm an ambassador and have been for several years, is because they're dedicated to scientific research and deepening the understanding of glaucoma. They're also focused on generating new treatments and ultimately finding a cure for glaucoma, which is what we all want. And these Schaefer grants, they provide seed money, like I mentioned, to investigators who have innovative ideas and creative projects so they can explore promising leads that show strong potential for an impact in glaucoma. The Catalyst for a Cure has been being pioneered for 20 years, and the investigations over the past 2 decades have really contributed to a shift in the understanding of glaucoma and opened doors to new therapies to protect vision towards vision restoration. So now that you've been fed lots of information, lots of inspiration about how to get action and oriented towards making sure you do all you can in order to keep seeing your best, we want to talk about next steps. What should you do next? Well, I suggest that you take GRF action. If you haven't already, you should check out their website. They have an absolutely amazing website full of so much information that's been vetted by glaucoma specialists like myself to be able to share with you the knowledge that you need in order to stay on top of your condition. You can share that website with other people. You can also, if you're not already accessing the free Gleams newsletter that gives information about research that they're doing, as well as common topics on glaucoma. You can attend their annual patient summit that's being held in June 23rd to 24th in Long Beach, California. And you can donate for a cure, help fund these research efforts to keep them going and help moving towards finding a cure for glaucoma. And then you can also take OKK action. You can order the book, the Glaucoma Guidebook, and you can share that with others and use the code, the discount code that we'll put up again for you to know, so you can get that advantage of taking the 30% off. You should also check out the website. There's resources within the website. It's called the glaucomaguidebook.com. There's also access to a free guide on the website in order to get your aha moments and your information on taking drops. There is a survey that was put out to glaucoma patients and specialists to find the top challenges in taking eye drops. And this guide shares solutions to those challenges so that they can help you get your drops better, help save in cost for the drops, help in better accuracy. And then also you can give me feedback. I love getting feedback. If you have a quote that you want to give, or you want to just give some encouragement for the things that you learned today, you can email me directly at info@theglaucomaguidebook.com. At this point, I am just thankful that I had the opportunity to share this information with you today. And me and Michelle are ready for your questions and to give you some answers.
Hi, Connie. That was amazing. All the information you gave, which was a lot of information and hard to give in so little time, but you summarized it beautifully. So thank you so much for that. We've definitely received several questions. I will try to pick and choose as many as we can since we don't have too much time left, but so there's one question, we've received it several times, a little bit about normal tension glaucoma. Like, what is it? What is the cause, and how can it be treated, or how does it differ from the other types of glaucoma?
Well, normal tension glaucoma is a subset of open angle glaucoma. And the reason why it's called normal tension is because the pressures when diagnosed with glaucoma are normal or low. A normal eye pressure is 21 millimeters of mercury or lower. And it's not uncommon for patients to be diagnosed with, say, a pressure of 15 or 14, but still they have some level of damage within the optic nerve. Our research has shown that even when patients have normal tension glaucoma, that they still need to be treated in terms of lowering the eye pressure, because that helps to slow down the progression of glaucoma. Sometimes people who have normal tension glaucoma also have some other associations like Raynaud's, which is a condition where there's poor perfusion in the small vessels that are in, like, say, their extremities, where they get, when they're cold, their fingertips get white. There's also sometimes association with, low blood pressure. And these are things that we take into account. Sometimes patients are told not to take their blood pressure medicine at night, which can sometimes cause poor perfusion at night and have sometimes an effect on the optic nerve. But by far and large, patients who have normal tension glaucoma still need to get their pressure reduced. And that's the way we treat it to help to slow down the progression.
Thank you. Another question that's kind of a two-part question, because many of the eye drops that people take to treat their glaucoma, they can have some side effects. And so what are the side effects that people should look out for and reach out to their doctor? And also, some people, because of these side effects, need to take eye drops that are preservative-free. And there is one person that's been asking, she's been having a very, very hard time finding these preservative-free eye drops for her husband, who she's trying to take care of. So do you have any suggestions, any tips for her?
Yeah. So side effects that you should, if a medication is causing side effects that cause you to not want to take the drop. So depending on the medication, we would call it hyperemia, redness in the eye. That's very common with certain medications. And typically that's mild, and it's something that is usually well tolerated. But if for any reason it's too much that you think that you wouldn't want to be using it, then you have to talk to your doctor to see if there's other alternatives. If the eye drops make your eyes feel itchy or scratchy, that's not uncommon. Some of these drops do actually dry out the eye a bit. And so sometimes you use those drops, but you also might use some artificial tears to help with those symptoms. If your vision is blurred, there are some eye drops that are kind of thicker or a little bit milky, and they can sometimes temporarily make your vision a little bit blurred. But if it's short lasting and not bothersome, then it's something that is not uncommon. But again, if these are symptoms that are concerning to you, you should bring them up to your doctor. Sometimes there's inserts in these medications, and sometimes they bring up, side effects that are very rare to happen. But if you are, there are certain classes of medications like beta blockers, which are systemic medications. Even though they go in the eye, they can cause, if someone has a history of asthma, sometimes it can exacerbate the asthma. It doesn't cause asthma, but it can exacerbate that. So there are certain systemic conditions that we look at to make sure you don't have when we're making decisions for which medicine to treat. Now, in terms of the person who is concerned about not being able to find the preservatives, talk to your doctor about those issues, because sometimes I know that there's one eye drop that is very gentle on the eye that is not typically found in pharmacies. It's found in a specialty pharmacy, and sometimes it gets erroneously sent to the general pharmacy, and then the patient can't get it. So sometimes there's an error on that part. So again, communicating. I do want to mention a certain product that's called the Nano Dropper that I've been using more and more of. This is a device that is placed on the tip of a bottle, and what it does is reduce the size of the drop to about 10 microliters. Most bottles will have a drop that comes out that's the size of about 35 to 75 microliters. The eye can only hold 10 microliters, and so there's always going to be spillover. And we've learned that the size of the drop can actually add to the side effect profile, such that if you use the nano dropper that makes the drop size about 10 microliters, sometimes it actually reduces the side effects. And the person who has the artificial tear need, there might be benefit of using the nano dropper to reduce some of the side effect profile that can work just as well as a preservative-free drop. So that's called nano dropper, and it's something that you can find and order online.
Thank you. That was very, very helpful. And yes, we know Nano Dropper as well, and it's a wonderful product. We recommend it as well. And if you're interested, they usually come to our patient summit too. And so we did have some questions about vitamins as well, different vitamins and supplements such as nicotinamide and ginkgo biloba and resveratrol. Do you have any recommendations, or what are your thoughts on these products?
Yeah, some of them, the ginkgo biloba, I know that there's a good association with it being protective of optic nerve tissue. I often suggest the use of a certain vitamin supplement called the optic nerve formula. And the reason why I like recommending this is because I know the research behind the ingredients that have an ability to increase the blood flow to the optic nerve. Now, we talked before about how we know that the way that we treat glaucoma is by lowering the eye pressure, but the use of vitamins to help increase blood flow to the optic nerve is a very supplemental treatment that we feel can support the environment of the optic nerve to help it maintain its health. So the optic nerve formula has been studied, and there's been evaluations of its increase in blood flow in certain measurements, and that's something that I recommend. The other vitamins that you mentioned outside of the ginkgo, I'm not as familiar with, and that's something that you can bring up with your doctor.
Thank you. Another question that has come up a little bit is about SLT and what your thoughts are about it. Some people have not had as much success with maybe their eye drops or other surgeries, and have heard about SLT. What do you think about that?
I'm a very big proponent of using SLT, and I use SLT even as first-line treatment. The way that I explain SLT is this. Just like light passes through a window, we have the ability to use light to apply to the natural drainage system of your eye. And this light is a cold energy, so it doesn't cut, doesn't burn. But what it does is stimulate the natural drainage system for the pores to relax and open up wider. That allows fluid to flow through. And we've been using this technology for 20 plus years, so we know that it works well. And there's a lot of studies now that show that it can actually sometimes work even better than using eye drops. It is something that is effective in the majority of people who have it. It can be used as first-line treatment. It can be used after you've had certain surgeries if your angle anatomy is amenable to it. It is something that can be repeated multiple times. It is something that when it's done, it has the ability to last for several years. I would say typically is about 1 year to 2 years, but I've seen 2, 3, 4, 5+ years. In regards to the light energy treatment, some of the things, it's an office procedure. You numb the eye, you walk in, sit down, they numb the eye, and the procedure itself takes about 5 minutes to do. Afterwards, your vision is a little bit blurred for a couple hours. You're typically back to baseline by that evening or by the next day when you wake up. I typically have patients use a certain type of eye medications that's a non-steroidal anti-inflammatory drop for about 5 days to a week after the procedure, just to help the eye heal, and then see them back several weeks later to look for an effect. Usually you're looking for an effect in about a 4 to 6 week range period. And sometimes it can happen earlier, but usually you give it that amount of time to see the full effect. And so I highly recommend it. It's something I've done thousands and thousands of SLTs. And so I know that it can work well, and it works well. At least about 85% of the time, we have a good pressure reduction. The pressure reduction is about that of what one medication typically can do, sometimes more.
Thank you. Thank you. That was a very, very good description of SLT. We do have actually just one question about SLT that just came in. Once you start on drop therapy, does taking drops for a few months make SLT less effective?
No. So typically what I do is I will, when I diagnose someone with glaucoma, I let them know about the 3 treatment options, which are drops, light energy treatment, and surgical options. Typically, first-line treatment is either the light energy treatment or drops, and I explain to them what the light energy treatment is. If they decide to go with the light energy treatment, I'll go ahead and put them on a drop that day so they can start getting coverage of their glaucoma right away. But the intention is that once they get their light energy treatment done, their SLT done, that I'm going to stop the drop drop that day after the procedure is done. And so it's very common for me to have them have their eye pressure lowered. So at least I have a trial of someone using the drop and seeing that they can tolerating it and see what kind of pressure reduction it gives, and then stop it so that they can then have the effect of the light energy treatment work, and they come back, and the majority of the time the pressures are reduced. So you can have use of drops for some time and then decide, hey, this drops and they're irritating me, or I don't want to use them, or too expensive. Can I try the light? Yes, you can.
Perfect. Thank you. And one last question. Because obviously, IOP, the intraocular pressure, does change throughout the day for patients. And many people, obviously when you go into the office, you try to go in always at the same time of day to make sure when you're comparing the results that they're always similar. But how do you monitor the rest of the day? Do you do that with other patients? Are there home tonometers that they can use? Do you discuss that with your patients, or what are your recommendations for that?
Yeah, I mean, in an ideal world, the patient would come back the same time of the day so we can get a pressure reading that's typical or similar. But that's not typically what happens. So they come at different times of the day. I don't actively use home tonometers in our practice. It's not that I don't necessarily think that they're good tools. We just haven't adopted that technology in our practice. It is something that people can use and give additional information. But remember, eye pressure is one way we check and evaluate for glaucoma, but it's not the only one. The main issue with glaucoma is damage to the optic nerve. So every time I see a patient, I assess the pressure, but I'm also looking at the nerve. And I use other tests such as the visual field and the OCT to be able to determine if those are stable or worse. And so if there's some changes in pressure, I can't just, be alarmed at, oh, today the pressure was 2 points higher than it was last time, and it's, 2 points above my target, but the nerve looks okay, the testing looks okay, that hasn't changed. So you factor in all these different things. That's why we take so many tests, because there's not one single test that gives us the right answer all the time. And so collectively, if the majority is in favor of stability with the test that we use, then we may say that the pressure today is okay. We'll watch it. Okay.
Thank you, Connie. Thank you for this wonderful, wonderful information that you've provided for us today. And thank you for your dedication to all glaucoma patients and glaucoma education. Please remember that if you want a copy of her amazing book, please go to her website. It is the glaucomaguidebook.com. And you can scan the QR code on the screen. And like she mentioned, you have a special code to save 30%. We have our 5th Glaucoma Patient Summit coming up on June 23rd and 24th in Long Beach, California. If you would want to find out more information, please visit our website, www.glaucoma.org/summit. We'll be putting up more information very soon, and registration will be able to begin soon as well. Thank you once again for being here with us and for joining us in our bold vision of a future free of glaucoma. Because of your continued partnership, the cure is truly in sight. Thank you, everyone, and see you next time.